Thank you everyone for waiting. I suggest we kick off now. So I will hand over to Preeti John, the moderator, to take us through today's session. Thank you. If everyone could confirm if you're able to hear us clearly, and if you're able to see the video, please let us know in the chat. And in case there are any challenges seeing the video, please let us know. Preeti, over to you. Thank you.
Thank you, Pooja. So a very good morning, probably good afternoon to some. And at the outset, I want to just take a moment to let you know that we will be recording this session. Should you have any concerns, please do let us know through the chat. Otherwise, we presume there is consent from all our listeners to record the session. So as Pooja introduced, I'm Preeti, and again, a very warm welcome to this particular new evidence webinar series that we are launching today. Today, the theme is Community Health Workers, Frontiers of Thinking and Evidence Webinar Series. As the co-founder of Women in Global Health India, I would like to take a couple of minutes to reflect on the remarkable journey of women in global health. Recognizing that 75% of the healthcare workforce are women, yet they continue to be minority in the decision-making space, as well as leadership space within healthcare. This realization paved the way for Women in Global Health, the global chapter, to be formed in 2015 as a movement. WGH functions in different regions through country chapters. Currently, there are 9 chapters with another 24 in the pipeline. The India chapter of Women in Global Health was initiated last year in 2019. Till date, we have completed a 5-part, 11-session dialogue series on frontline health workers under the Amplifying Women's Contribution and COVID 50-50 campaign. WGHI continue to be advocates for decent pay and safe working conditions for frontline workers, besides advocating for panels instead of manels. As COVID-19 spread globally in March this year, the India chapter recognized the crucial role of the frontline health workforce and sought to provide a platform to not just share best practices and learn from each other, but also to amplify the contributions, highlight challenges, and present it to the policymakers. The 5-part WGH India Dialogue series set the stage with the theme focusing on ASHA workers in June, the ANMs in July, women collectives and self-help groups in August, elected women representatives from Panchayat Raj institutions in September, and we just concluded it last month with the allied and health professionals. Each of these sessions had 2 or more parts, with the first one focusing on stories and reports from the community or the frontline health worker itself. The second session focused on hearing the perspectives of the policymakers who influence key decisions in this arena. These 11 sessions were made possible due to the synergistic partnership of WGHI with Answers, Roshni, C3, Women in Politics, Policy Corps as knowledge partners, to name a few. And today, this program is kicking off a new webinar series This multi-part webinar series is being held in collaboration with Oxford Policy Management. Oxford Policy Management has been working closely with Priyananda and the Gates Foundation on a frontline health worker grant. And over the last couple of years, OPM has generated tremendous evidence on the functioning of the community health workers. And at this point, I'd like to take a pause and introduce an expert in this arena, Dr. Priyananda. She is the Senior Program Officer, Emily, at the Bill and Melinda Gates Foundation. And she has always been a keen motivator and support on the ongoing work of the CSWs over the last several years as part of the foundation. And as we start this session, I would like to request her to present on setting the context to this webinar today, and indeed on the CSWs. Over to you.
Thanks, Preeti, and welcome everybody. Welcome to the first of the OPM Women in Global Health webinars on the issue of community health workers. We are very excited because this is culmination of a 3-year investment in OPM to develop and synthesize and conceptualize and reconceptualize evidence on community health workers from the perspective of community health workers themselves, their level of efficacy and agency in the work they do, how connected they feel and to the health systems and the communities that they work in, and to what extent and how are they motivated and supported in the jobs they do. So very early on, OPM has been reinterrogating the evidence and reconceptualizing it in terms of a framework to help us think about the role of community workers in terms of their means, their motives, and the opportunities, which is the larger enabling environment of the system in which they work. And that has been really helpful and helped us at the foundation and also our partners to think about new ways in which we want to collect evidence on community health workers, but also what are the implications for policies and programs, especially in the states in India that we work in terms of really trying to lift the status and improve the role clarity and enhance the abilities and capacities of community health workers, because we know a lot rests on them. A large proportion of our outreach work and burden of reaching families in communities, especially on RM and CH outcomes, rests on our outreach workers. So I think we've all been looking at the evidence around the coverage of outreach workers to families, and then as a result, whether we see improvements in some of the outcomes, such as improved reduction in mortality or improved health practices at the community level. I think where we have a little less understanding is what is the quality of this outreach. So we have evidence on the fact that actually community health workers do improve equity. They do connect families to health systems or individuals to health systems in instances where otherwise that access is not there. And that connection is a really important part for us to achieve our equity and health goals. However, what we have very little understanding is the variable and heterogeneous aspects of quality of this coverage. And therefore, you see that improved coverage does improve outcomes in some instances, but they don't in some instances. There is also the understanding that there is a large there's a heterogeneity in even the skills and capacities of community health workers as such. As most of you know, these are women they're largely women to begin with. So it's a highly feminized workforce. And they bring with them into the health system that they work in all of the gender barriers and constraints that they face in the communities. And then they work in very hierarchical gendered health systems. So on both ends of the continuum, I think they get reinforced by all of the gender power inequities that they face in their homes, communities, as well as amplified within the health system. On top of that, I mean, the level of skills and training or education that they come into their work with is too low to begin with. And it is intentionally so because they're considered voluntary and largely only paid or remunerated for certain kinds of tasks they do, and in some instances not compensated for other tasks. Now, that is also different for different levels of community health workers, and they're not all equal. But all of that points to how easily we disregard their professional status and the immense importance of the work that they carry for us in the community, in fact, carry a large aspect of our mantle for universal health coverage. So this webinar series was actually designed pre-COVID to really bring existing evidence to bear, and we were working with other partners who are also doing the same. But because of COVID, I think there was a resurgence and a re-recognition of not only the importance, but also some of the failings of the health system to really empower and imbue the status that they deserve in the work that they do. And what's been exciting is that resurgence has really brought the attention to community health workers with new partners like Women in Global Health. So I think OPM is very, I think it's really opportune that these two organizations have partnered on this. So I think in terms of context setting, this is the first of the panel series. There are 6 others. They're going to really look at not only community health workers as women, and whether the first webinar is really provocative to ask, what are the limits to performance without empowerment, or what are the limits to empowerment? And I hope we will have a rich debate on that. And from here, systematically, we are really going to look at how embedded are health workers in community, what is their role in creating for resilient systems and resilient communities. Can digitization and technology really bring performance and empowerment in a much more convergent way that was not possible without digitization? And lastly, the large question: how much of our universal healthcare agenda really rests on community health workers, and what do we need to really do if it does largely rest on the shoulders of community health workers? I think another unfinished question which we don't discuss, and I don't know whether there's possibility to do that without big policy changes, is that why is the SCADA worker largely feminized? And are there ways that we start shifting the gender ratio, and with equal pay and professionalization for women in community health work? So with that, these are really just, I'm excited about the panel, so I don't want to speak too much, but we'll come back in the discussion, and I hope all of you will actively engage and chat with your questions. So back to you, Preeti, and thanks.
Thank you very much. I think, Priya, you beautifully laid the context in terms of actually raising the relevant questions as to why we are here in this panel discussion. So certainly, from a human resources and healthcare perspective, it is very, very important that the focus of this webinar series is on the community health workers, as they kind of serve that crucial link between the formal health system and the different communities they serve. And not only do they play a key role in providing that health services to the community, particularly in low resource settings, but like Priya just mentioned, this is kind of like the main contact point which people in the community have with the formal health system. And Definitely, the COVID has only sought to increase the spotlight on this group. So this webinar is extremely timely, as definitely this group is being acknowledged as crucial to accelerating the progress towards universal health coverage and the SDGs. And so let us reflect on some of these questions about community health workers, performance perspective, empowerment perspective, building the resilient health system perspective. And let's move to listening to the speakers. I'd like to take a moment to introduce the first speaker, Amit Kumar from Ekjot. He has extensive experience as a development professional with a number of national and international agencies. His core competency being in program development, in health, nutrition, and elementary education, besides training and team building. He has led, scaled up, proven community approach, participatory learning, action plan, both in Odisha and Madhya Pradesh. And currently, he oversees Ekjot scale-up in Jharkhand, Rajasthan, alongside the expansion of the PLA approach in Assam and West Bengal as part of the senior management team. So over to Amit to really understand the actual community experience from the work they have been doing for several years.
Thank you, Preeti, for that introduction, and good morning to all. Today's discussion is about frontline health workers or community health workers and how they can feel empowered. Let me begin by sharing some of the aspects that helps a woman and community in general to feel empowered. Our experience tells us that if agency improves, then women feel empowered. If the relationships are strong and supportive, they feel empowered. If the environment is enabling, they feel empowered. So I would like to discuss this further with reference to a couple of studies that we have done in the past, and would like to bring the discussion to a point where we can see these changes from an empowerment perspective. The first study I would like to show was done between 2005 and 8 and was in 3 districts, 2 from Jharkhand, 1 from Odisha. And here women from the communities were identified as facilitators of a participatory community process, which is called participatory learning in action, and first tested it through this study. And as you can see, the results were pretty encouraging. There was 32% reduction in neonatal mortality in 3 years time frame. If we consider the last 2 years of the study period, this reduction was 25%. There was also 57% reduction in postnatal depression, what we realized. And these are the learnings that we got from the first trial that we did. And this also gave us the confidence to build it further. The next thing we realized that the agency among women also increased in the intervention areas where they were more forthcoming in terms of contributing to their own and family's health, also in terms of being part of the decisions which are taken at the household level. And these results were also acknowledged in terms of earning us the best paper published by Society of Clinical Trial, also published in the Lancet. And in 2014, WHO globally recommended this approach to address maternal and newborn issues. I would like to go to the second study where this was tried with ASHA workers as the facilitators. And it was again done in 5 districts from Orissa and Jharkhand. And the trial was called Johar, Jharkhand Orissa Health Action Research. And Johar is also how you greet people when you meet first in Jharkhand. So here we found 31% reduction in neonatal mortality compared to the control areas. So we learned that the approach can be effectively implemented with community health workers or frontline health workers and bring similar results when done on the ground. So from these two studies and few more studies that we did simultaneously, we came to a stage where it was about scaling this up and making sure that the benefit reaches to as many as possible. I'm sharing the scale-up experience in Jharkhand, where National Health Mission Government of Jharkhand is scaling it up across the state, that is covering all 24 districts, 196 blocks. And the cadre who are engaged in this scale-up are around 40,000 ASAs, supported by 2,200 ASA facilitators, covering a population of roughly 32 million in the state. So here, the meetings, the PLA platforms are used by these facilitators, these ASAs, and there is a training that system that has been put in place where the executive training team trains the national training team, and then it goes to the state training team, to the block training team, and Sayya Sathis or ASA facilitators are trained on that. We also did this scale up in a staggered manner, and it has been almost 5 years now since we are scaling it up in Jharkhand. So we started it from 6 blocks in 5 of the commissionaries, then moved to saturate those 6 districts, and ultimately reached to the entire state through this approach. So in terms of capacity building, when we were thinking of the scale up, we also realized that training 40,000 odd ASHAs will require a lot of time, can be a very resource intensive process, and may be very challenging in terms of quality, as others were also mentioned. So we came up with a strategy or an approach of training the ASAs on the job. And I would like you all to quickly take through the process, which we call odd and even approach. So what we have realized that in most of the states, one ASA facilitator is responsible for roughly 15 to 20 ASAs in terms of supervising them. So in this very approach, the ASA facilitator cadre is trained on the PLA process. And while she is planning to extend support further, she numbers all the ASAs under her supervision, and she picks, say, even number ASAs for the first meeting. So what she did, she picked, say, 2, 4, 6, and so on. So half of the ASAs she picked, and she herself went there to their areas and conducted the very meeting there. When she was conducting this meeting, the ASA from the neighboring village, or who is a learner ASA, comes there, gets herself trained on the job, goes back to her own place and conducts this very meeting maybe the same day or next day. When the ASA facilitator is planning the next meeting, say meeting number 2, she now picks up odd numbers ASAs, goes to the odd number ASAs, conducts this meeting in her area, where even number ASAs who are in the neighborhood comes there, gets herself trained on meeting number 2, returns to their own catchment area and conducts the very meeting. So there were a few things that were made possible through this strategy. One was the entire training load was reduced significantly. So it was reduced by more than 90%. And the budgetary requirement for capacitating was also reduced in a similar fashion. Yes, when we were planning this, we were concerned about the quality in terms of whether this very approach will have its impact in terms of quality when these ASAs, after getting on the job trained, going back to their native place and conducting these meetings. And we realized during our first year, when we were trying it out in 6 blocks, that it worked well, and ASAs were in fact happy, and we will see that when we come to the sharing of their experiences. So again, coming back to the empowerment perspective, why all these results were there? Why there was reduction in neonatal mortality? We feel that it is because community were capacitated, women were able to take decision, women were able to understand the underlying causes and relate it with their practices, and were ready to change things around their own and their families' health. And this entire empowering the community happened because of the facilitators, and in most of the cases, they were the ASAs or the community health workers. So I believe that these changes were possible because community health workers, we believed, and the system believed in their sincerity and commitment towards the cause. We all invested in building the skills and knowledge of this cadre. We had equipped them with simple and effective tools and platform to carry it out effectively. And I believe that there was an enabling support system which was created, which not only recognized but also respected their valuable contribution and role in doing that. Now, I would conclude with a small video where some of the ASHAs are sharing what has been their experience going through the PLA process. And there were different designs. So as part of the video, you would listen what has been their experience as part of different PLA design, and also about this odd and even on the job training approach.
PLA मीटिंग के द्वारा आज हम लोग पूरा खुल के बोल पाते हैं, कहीं भी कुछ भी समुदाय बैठक होता है तो 100 महिला से भी पार हो जाती है, तो वैसे जगह में भी खुल के हम लोग बोल पाते हैं, तो बहुत अच्छा लग रहा है। आगे भी चाहते हैं कि इस तरह से बैठक होता रहे।
PLA आने के बाद में हम लोगों को बहुत आसानी हुई, कहानी के माध्यम से, नाटक के माध्यम से, कि हम लोग समुदाय को बहुत अच्छे से समझा पा रहे हैं। हमारे पदाधिकारी भी हैं कि इसमें भरपूर सपोर्ट कर रहे हैं, और बिना उनके सपोर्ट का हम लोग कुछ भी नहीं कर पाते। इसमें हमारे समुदाय के आदमी भी आ रहे हैं, और जहाँ भी हम लोग को थोड़ी बहुत कठिनाई होती है वो उनको समुदाय को समझाते हैं और हमारी मदद करते हैं।
ये हिंसा में काम करते करते हम इतना, मुझे ताकत मिला कि एक महिला के साथ इस तरह का होता है तो शायद मेरे गांव अगल बगल में और भी किसी महिला के साथ होगा। लड़ाई झगड़ा गांव में होता है तो तुरंत हम लोग उसका बैठकी करके और उसका समाधान हम लोग करते हैं।
कौन सा अच्छा है वो वाला कि
10 दिन का होता है ना, तो लगातार मतलब हो जाता है ढेर सारा मीटिंग का बारे सिखाया जाता है हमको। हम लोग को तो इतना दिमाग नहीं रखता हम लोग को। अरे एक महीना में एक ठो होता है तो अच्छी तरह हम लोग एक चीज से याद हो जाता है। एक मीटिंग में एक होता है।
Thank you, everyone.
Thank you very much, Amit. I think on behalf of all the audience who are listening here, I think all of us would like to take a moment to say probably Johar to all the amazing Ashas and Asha facilitators who are just doing so much tremendous work. And thank you so much for bringing us the community perspective. And now moving over, I would like to invite Shruti Srinivasan, who will be presenting the barriers to performance of the Anganwadi workers in Bihar. And Shruti, just to tell a little bit briefly about her, Shruti Srinivasan completed her PhD in understanding the motivation and performance of FLWs under the public programs in 2018. And she's presently working on the FLW learning grant at OPM and focusing on measurement, learning, and evaluation component across different work streams under the grant. So I invite Shruti to present about the Anganwadi workers in Bihar. Over to you. Shruti, you're on mute. It's still mute, yeah.
Yes. Is this better? Can you hear me?
Yes, thank you.
Thank you. A very good morning, everyone. Good afternoon, everyone. I'm here to present the work that my colleagues and I at OPM are carrying out, which attempts to understand the performance of community health workers and attempts to understand the position of these health workers within the larger community health systems, and tries to advocate that these two aspects are in fact interconnected. Today, I'll be presenting the means, motives, opportunity framework, which is a diagnostic framework to look at the performance of health workers. And for today's discussion, I'll be restricting the conversation to one specific cadre of health workers in India, which is the Anganwadi workers in the state of Bihar. So to start with, an Anganwadi worker is a contractual employee receiving an honorarium under the nutrition policy in India. She operates out of an Anganwadi center or a daycare center, and she critically influences the delivery of several nutrition and early childhood care-based services. The criticality of her role is indicated by the fact that a network of about 1.34 million Anganwadi workers cater to the health and nutrition requirements of over 100 million women and children across the country. I'm not able to move the screen. Thank you. There's a lag, guys. Sorry, just a second. So now that we know that her role is important, what we see in terms of her service delivery is that okay, something else is happening, sorry. Yeah, in terms of service delivery, what we notice is that while her role is important, the National Family Health Survey data from 2014-15 suggests that a majority of the eligible beneficiaries, that is lactating, pregnant women, and children in the age group 3 to 6, do not receive any benefits from the Anganwadi center in the state of Bihar. And this statistic becomes very crucial because this trend and the way you read this trend and interpret this trend also affects the manner in which you design solutions. Can this gap be attributed to any gaps in terms of the performance and motivations of the Anganwadi worker, or is it an entire other gamut of factors that affect this trend? So an investigation into the reasons for this led us to look at literature in public health systems, in organizational behavior, based on which we find that performance is effectively an interaction between the motives of, I'm sorry, this is, there's a bit of a lag in how thank you. So based on this, we realize that performance is basically, it depends on the interaction between the motives of an individual and the constraints she faces in doing a certain activity. So if you were to circle back to the statistic, the gap or the puzzle of suboptimal performance and coverage can either be attributed to the Anganwadi workers' gaps in motivation, which therefore implies that our interventions need to target that motivation deficit through incentives and disincentives, or alternatively, it allows you to acknowledge that there are a variety of other constraints that act as a binding constraint. which may lead to a different set of solutions, which is about creating an enabling environment within which an Anganwadi worker can perform. Now, the latter is also the dominant conversation in more recent public health literature, which says that to design interventions, you need a very acute understanding of the motivations of these workers and an understanding of the context within which these workers function, which are themselves very complex, dynamic ecosystems, which are marked by relations between the health worker and the various members within the community health system. So any intervention that targets improved performance must necessarily build on these relations and not undermine her position or her relationship with the various members. So with this background in mind, I present to you the means, motives, and opportunities framework. And every time I jump, it sort of skips a slide. So when we talk about the means, motives, opportunity framework, talks about three interacting domains, which together explain the reasons that affect the performance and the service delivery of Anganwadi workers. It constitutes of means, which is whether she has the capacity to deliver, motives, whether she has the intent or wants to deliver specific services, opportunity, whether she has the chance to deliver these services. Now, these three aspects together are further subdivided into 14 interacting categories that work together in different ways to affect service delivery to varying degrees. We use this framework to understand the performance of Anganwadi workers in the state of Bihar. And in doing so, we relied on a large repository of primary and secondary data, which drew from both qualitative and quantitative insights. And here I am to present a synthesis of these findings. So to jump into the findings, when we look at the motives aspect of it, we see that it was a critical binding factor, because what we notice is, based on survey results that we undertook, that Anganwadi workers had low levels of technical knowledge. And this was in spite of the fact that there was a higher frequency of training. What we also observed was that the Anganwadi workers' direct supervisor had knowledge levels only marginally better than the health worker. Additionally, we know very little about the skills and the broader competencies required by the Anganwadi worker to perform. Therefore, in the absence of requisite knowledge, in the absence of skills, these means became critical challenges affecting the workers' service delivery. Moving on to the next domain, which looks at motives. What we observed was based on reading some of the latent constructs of motivation and job satisfaction. What we find is that most Anganwadi workers reported to be driven by external regulation. Now, external regulation effectively is your responsiveness to external stimuli, which could be in form of rewards and how reactive you are to rewards. However, what we also observed was that, I'm sorry, I'm not able to move to the next screen. I don't know why there's a lag.
Shuchi, can you,
Yes.
sorry to interrupt everyone, can you give up control and I will move the slides? I think there's a bit of a challenge. So you're on means, right?
I'm on motives now, the first slide. I just gave up control. Thank you. Sorry about this, everyone.
No worries, and just tell me when to go next and I'll move ahead, yeah? Thanks.
Okay. So when we look at the motives domain, and based on our initial reading and work on the motivations and job satisfaction of Anganwadi workers, what we see is that Anganwadi workers reported to having high levels of external regulation. That is, they were motivated by external rewards. However, what we did notice was that the motivations were not correlated with performance. Additionally, what we also find is that while more moral drivers to perform the work of an Anganwadi worker were very strong, but the desire to earn a remuneration and a salary were also equally important. And this is essentially because the Anganwadi worker is a woman from a poorer socioeconomic background whose remuneration contributes on an average to about a fourth of a household income. What we also observed was there was a very high level of dissatisfaction with the amount and the timeliness of the incentives. And in order to cope with this, most of these workers also resorted to other behaviors which relied on pilfering some of the rations at the Anganwadi center. Pooja, can you please move to the next? Thank you. Next, please, Pooja. Thanks. What we also saw was that the Anganwadi worker identified herself as a teacher in the community. And this also was the dominant, Pooja, can you move to the previous slide, please? Yeah. She identified herself as a teacher, and this was also the dominant role that she played. What we observe is that she also stated to providing biscuits and toffees to the Anganwadi attending children to sustain their interest in preschool activities, which was also a trend that she was seen to replicate when dealing with beneficiaries, because beneficiaries were seen to have a clear preference for product-oriented services like take-home rations. And sensing this pattern, she offered snacks and tea to encourage take-up of other services like group counseling. Another aspect within the motives which came out very strongly was that of supervision. Now, globally and in India, there is evidence that suggests that supervision is associated with improved community health worker performance. Whilst this is the case, what we observed in the case of Anganwadi workers was that the supervision that they received was routinely very punitive, very hierarchical, and mostly based on checking registers and very audit style, which may have been counterproductive. So the summary of the story is that we don't see any evidence that the lack of motivation is a barrier. In fact, what we see is that the Anganwadi workers are working very hard to keep their jobs. In fact, resorting to some discretionary and coping behaviors to sustain service delivery. And there's no evidence of shirking. Pooja, can we move to the next, please? Thank you. In terms of the opportunity level determinants, we see that this was the most binding constraint upon performance. Looking at access, we see that 20% of the Anganwadi centers were not operational. What we also observe is that the supplementary nutrition allocations were based on very outdated population norms, and they catered to only 44% of the eligible beneficiaries. Now, this is problematic because beneficiaries have a preference for product-oriented services, and not receiving the necessary services may lead to friction between the health worker and the beneficiary. Another aspect that emerged very strongly was that safety was a major determinant of the ability and a determinant of whether the Anganwadi worker would undertake home visits. But what we observed was that 17% of the Anganwadi workers were not completely satisfied with the safety in carrying out work in their communities. In addition to it, we also noticed chronic shortages in resources and infrastructure, in equipment. To give you an example, about 73% of the Anganwadi centers did not have a functional toilet. 74% did not have complete drug kits, which had shortages of drugs like albendazole, ORS, paracetamol. Pooja, can you move to the next slide? Thank you. Another opportunity level determinant that became very important is whether the worker had the legitimacy to carry out specific behaviors. And this is where the caste dimension became very important, because if a beneficiary belonged to a higher caste, there was a reluctance to take services from the community health workers from lower castes. And this created a problem in actually delivering the service. An additional aspect that hindered service delivery was also her workload. About 11% and only about 11% of these Anganwadi workers were completely satisfied with their existing workload, and most felt extremely burdened. So together, what we see is that the opportunity level determinants were the most binding on performance. Pooja, can we move to the next one, please? Thank you. So to conclude the story, what does all of this mean? Well, it means that Anganwadi workers seem to be expending very high levels of effort, but they systematically lack the resources to carry out the necessary roles. What this also tells us is to go back to that initial assertion of how you read that statistic and the puzzle of suboptimal performance. Because if you persist to see it as a motivation challenge, then the solutions you propose in terms of improved incentives or stronger monitoring are unlikely to have a cascading effect on the performance of these workers unless some system level bottlenecks are addressed. This trend of sort of placing the blame on the health worker is reflective of the idea that the worker has agency over the outcomes, firstly, which may not be true. Secondly, it equates the system of providing the necessary support and resources to the worker to carry out her role. And finally, it fails to acknowledge the fact that these workers feel disempowered and they're disrespectfully treated. And this undermines their ability to forge those strong, trusting relations with the various members within the community health system. To come back to the theme of this webinar, now empowering community health workers does require a very different class of solutions. And this begins by acknowledging that you need to engage with her, you need to support her agency. And this can be done by providing her with the necessary training, support, resources, and most importantly, the dignity of labor so that she can deliver. The last line that I'd like to leave you with is that the empowerment agenda becomes even more important in the face of the changed context that we live in, which is the post-COVID world, where we see that resilience objectives and future preparedness efforts are actively being sought by health systems. And this has also led to an expanded role and responsibilities for the community health workers. With that, I'd like to thank you. Thanks.
Thank you so much, Suchi. I think, as we are listening to this webinar, I would also like to take a moment to recognize that the Anganwadi workers are out there in the front line working. So a huge thanks from us to that group as well. And now switching over we're going to listen to the third speaker of today, Dr. Sumit from University of Melbourne. Sumit's research focus has been on low and middle income country societies and health systems transitioning to a post-service availability phase. He has been tremendously interested in the responsiveness of health services, and his research questions these transitions. His research examines the questions these transitions raise for health service organizational requirements, particularly relations between people and organizations, as well as between organizations and between people or organizations and institutions. So over to you, Sumit.
Thank you, Preeti. And good morning, good afternoon, good day to people from all over the world. Over the next 10 minutes, I would like to get into a conversation of sorts, if you may, with what Amit and Shuchi have presented so far. I would also like to bring into this conversation some reflections on the work I have done together with colleagues earlier in Amsterdam, good friends, and now at Melbourne and Pune. I want to take this opportunity to give a shout out to them. Some of them I see as participants sitting in Malawi and in Pune. Our early work on this subject of CHWs was oriented towards trying to understand what constrained and what enabled CHWs across different parts of the world to perform their roles properly. In doing this research, it occurred to me that while we may be interested in performance, CHWs, and while they are also interested in improving their own performance and in doing their job well, we're also busy doing something else. That is making the most of the opportunity of being a CHW. This led us to start looking at the experience of being a CHW and working as a CHW much more broadly. In 2015, me and my colleagues back in Amsterdam examined our data from the 6-country study using empowerment as a lens to understand what being a CHW was like. And we identified many of the things that Amit and Shuchi have talked about. The empowering influence of access to new knowledge and competencies, the empowering effect of the opportunities to step out of homes, the empowering effect of feeling of being a part of something important and big, and of doing meaningful and socially relevant work. We also identified these empowering influences as being at odds with a whole range of structural issues around how CHW programs were organized. The managerial and program imperatives to maintain control and achieve targets, the hierarchy in the relationships between formal health workers within health facilities at the front line, the larger bureaucracy of the health system, and also some of the community dynamics within which all this was happening. You would agree that the focus on empowering CHWs has kind of become mainstream now, and rightly so, I would say. Let's pause here a bit and let's just think about how we talk about empowerment. How do we talk about the empowerment of CHWs? In the research that is out there, in the program documents that are out there, in how experts talk about it, in the titles of the seminar that we are in. You hear things like, you read things like how important it is to empower CHWs, how health services change the way they function, how important it is to try and find new and innovative approaches to empower CHWs. These concerns, this research, all of this is helpful and useful. But I argue today that it somehow paints an incomplete and inaccurate picture. In fact, it somehow is even unfair to how CHWs are and how they work and how they conduct themselves, because the discourse it employs is problematic. Now, if we look critically, what do I mean? All this talk of empowerment connotes that something that someone else, someone better, someone more powerful needs to step in to give or grant to CHWs. I find this discourse very problematic. As I increasingly encountered this discourse, I wondered if CHWs really needed saving, whether they really needed empowering. I wondered whether these proclamations for the need to intervene and empower were really true. What we had seen in the 6-country study data suggested otherwise. CHWs seemed to be busy making the most of the opportunity of being a CHW. I decided that I had to go back to the field, spend time interacting with CHWs, try to better understand what they were experiencing. It was then that I initiated the study on ASHAs that has recently been published 6 months ago. What did we find? Far from being the powerless and weak as the literature tends to portray them, ASHAs in our study were very skilled social actors. ASHAs, we saw, devised and applied sophisticated and nuanced strategies to get their work done, to get the most out of the work they did for themselves, for the community they serve, and for the health system they work for. Not always in that order and not always in that priority, of course. We found that ASHAs had cultivated and had accumulated substantial social and network capital and relational power. It shouldn't come as a surprise to anybody. After all, they had deep links within the community, have had time to establish a social standing, have institutional memory, and have a deep understanding of local social dynamics and politics. One ASHA told us, yes, it was inconvenient. She said, I had to go out of the way to accompany this family to Pune, to stay overnight for 2 days, but it was all worth it. The mother and the child were saved. They bless me even today. And also, if I hadn't done it, I would have lost all credibility with my people, and they would stop using my services. We found that ASHAs use what I call spontaneous everyday power to get their work done. One ASHA narrated an instance of how, in the process of organizing a referral for a very poor family, while the local health center staff had given up, she took the initiative to call the sub-district medical officer directly on his phone, got him to organize things, got him to commit to reimburse the costs that she was personally incurring for the poor family. We found that ASHAs use this spontaneous everyday power to also reconfigure the status in their relationship with community members and within their families. We found that over time, many ASHAs had also successfully reconfigured the relationship with primary health center staff such that they were no longer the less powerful party, and in some ways had clearly become their equals. Let me pause briefly. Pooja, I'm unable to transition the slides. Is it possible for you to?
Yes, Smith. Should I go to the next one now?
Yes, please. Yes.
Yeah.
Thank you. So as I was saying, we found that ASHAs had also configured the relationship with primary health center staff such that they were no longer the less powerful party. And this is what we find in the paper that we recently published in IGHPM. And in some ways, they had become clearly the equals of the health worker in the health facilities. We found that while ASHAs had accumulated and wielded power, they were always conscious of the unequal and gendered power relations they were part of in society and in relations with other health workers. We saw that they navigated this terrain with great dexterity, with remarkable pragmatism and deep understanding of what is possible, what was not possible. On one hand, ASHAs were pragmatic about their situation and focused on achieving their immediate instrumental goals, getting incentives, maintaining relationships and credibility. On the other hand, ASHA's actions were also acts of subversion and resistance against these entrenched and gendered structural inequities that they faced on a daily basis at home, in society, and in the health system. In response to a question about whether it was impossible to work as an ASHA without family support, one of the ASHAs responded, and I quote, "Indeed, that is so. It is so with me too," she said. And she paused and she said, "You know what? My husband is different." She hesitated. She said, "He doesn't really work. He drinks." And then she became animated and she started saying, "He talks and talks and he berates me. And he says, 'Why should you do this work? Just leave it. Why do you have to work?' And I say, 'It's my wish. I want to do it. I won't leave it. I'm not going to leave this work.'" She paused. And I waited and I waited and I then asked her, "So you're doing this against his wishes?" She said, "Yes." And with steely resolve in her eyes, she said, "Yes, I'm doing it." In another instance, an ASHA explained to us, and I quote again, "Family members say to me, 'You work, how much do you make?' They say, 'You don't have a salary. Why do you do this work?' She said, then I say to them, 'I work because I want to. I work because it is my desire. I want to work whether I make money or not. I feel satisfied." Of course, it is not possible for me to share all which we found in these 10 minutes. So I invite you to read our papers, including the recent one in IGHPM, from which I'm drawing. But my point today is, and I make this point in conversation with Amit and Shuchi's presentations and Priya's comments, and in reflecting upon our own work, that yes, many, if not all ASHAs stand from a position of systematic disadvantage and low power. And yes, we need to intervene to make changes to the structures that disempower ASHAs and to find creative means and to create real actionable opportunities such that ASHAs can be empowered. But also that it is equally important to recognize that these women aren't really waiting for some savior to come and to empower them. They have been busy. They have been busy slowly accumulating power for themselves. And as you will see in our ASHA paper, wielding this power with great finesse. Today, I argue that recognizing this agency, respecting this agency, as Amit talked about in his presentation, is, if not more, as important as systematically dismantling the structures that disempower ASHAs, as important as creating opportunities and providing the means for ASHAs and CHWs to become empowered. Thank you. Pooja, next slide.
Thank you very much, Sumit, for your, there are a lot of evidence that you have been able to build forward, bring forward. And I think we just need to really appreciate not just the wonderful work our CHWs are doing, but also the fact that we really need to appreciate and take it really mainstream and put spotlight on them. Then it is about getting better evidence out. So I'm just going to open this a few minutes we will take for the panelists to respond on a couple of questions. There are already several questions which our audience is also asking. Some we are trying to answer on chat itself, but we will also take up those questions. So at this point, I would like to ask each of you speakers to kind of reflect. You know, we have been talking broadly on the theme of empowerment of the community health workers. So if you could kind of say 2 key lessons that you would like to draw from your work to improve the existing policies for empowering CSWs, what would it be? Should I request Amit? Would you like to start by giving your key thoughts?
Sure. And thanks that you asked that. While I was sharing our experience, the enabling environment bit, I think, lies to a great extent on what kind of policies and what kind of structural arrangement we have brought in. And in case of Asha, as other panelists also pointed out, some of the things which we have seen really work in terms of motivating them, in terms of also giving them the confidence of carrying the good work forward. It is recognition of what contribution they are making, what effort they are making. I would just like to share a small example that around a couple of years back, it was the mid of the scale up, we have had a Asha conclave where around 1,000 Ashas from all the districts were gathered together, and it was celebrated more than kind of shared. So it was a platform where they shared what they have achieved in front of bureaucratic and political leadership. At the same time, they also danced their heart out to the tune of local music. And the whole feeling, the whole atmosphere was so positive, and that resonates even today, even after 2 years. So the point I'm trying to make here is that the recognition needs to come from all who are involved in this process, primarily from those who supervise them, and from them it would come if they are also recognized by their supervisor and so on. So that's one thing. Second would be to streamline some of the things which are not that difficult to streamline. For example, timely payment of incentives. The ASA cadre is incentivized, and that has its bearing in terms of their motivation. And if that small meager amount which is supposed to gets delayed by, say, almost a quarter or 6 months, that has a demotivating effect on them. And thirdly, I think from the larger perspective, how this cadre is going to get to the level where right now they are looked at by the community, especially in health-related issue, but also in terms of a leader who can guide the larger developmental agenda. I believe a lot of input has gone in terms of different modules that has been implemented in terms of training these ASAs, but more concerted kind of engagement where we really develop these Asha Didis as leaders in the community, and community people also start looking at them as leaders. So I think those will be some of the points I would like to mention. Thank you.
Okay, thank you so much. Shuchi, what are your thoughts?
I'm sorry, I lost the internet for a split second. Can you repeat the question? I'm so sorry about this.
We are looking into, as you reflect on your own work and you're thinking about empowerment. So from a policy perspective, what would be your 2 key thoughts?
When we're looking at the empowerment perspective, I think it starts with creating that environment wherein the health worker feels respected. And I think that starts with providing her with the necessary support in terms of where this work can be taken forward. I think is to inculcate the idea of supportive supervision of the various cadres of health workers, which would be very important. The second aspect that I think would also be a good direction to take the empowerment agenda forward is through skills training. And when I say skills, I don't mean technical skills. I mean transferable skills, skills that are agnostic to the task that you're performing and are more towards communication, negotiation, leadership. So things that actually lead you to perform that role of an agent of change in the community and not necessarily a conduit for service delivery. So perhaps that would be a good way to sort of also work with this evolving cadre of workers and empower them to be more effective. So those are my 2 points there. Thank you.
Okay. Thank you. And Sumit?
Thank you. Yeah, I would like to echo some of what Amit has said and Shuchi has said, and also pick up on some of the chat that is going on. And I agree with what Priya Das and Priya Nanda have put in the chat boxes. And in fact, there are differences. That's what we found in the field work between different ashas. Who was able to accrue what power, what were they able to do with the opportunities that they got. And you're rightly pointing out that this would also differ across contexts. What an asha is able to achieve within the context of UP, Odisha, Maharashtra, or a CHW in Uganda, Kenya would be very different. And we need to, that's the important thing, we need to take this into account. In any attempt and to create the environment for ashas and CHWs to feel empowered. So that's one point. There is something also more, something slightly more controversial, if you may. You know, the whole idea of empowerment and is underpinned by conflict theory, right? And the idea rests on the assumption that conflict rather than cooperation between groups for control over resources, for control over opportunities, for control over power, for the lack of a better term, is at the heart of any attempt to empower. So people have actually even questioned within the context of organizational settings, within the context of organizational change efforts, whether it is actually possible to empower others at all, because it requires a redistribution of power. And institutional structures are such that they put one group in a position of power over others. And if that group is in a position to empower others, that itself is a self-frustrating argument. So we need to provide opportunities, the means have to be there, people need to be enabled, and so on and so forth. But at the heart of this question is the idea that, okay, this is a contested space where people are jostling for authority and resources. We need to recognize that and tailor our approach to that.
Okay. So, you know, as we listen from all the research work that you're doing and the evidence that you're bringing out, we're seeing certain paradigm shifts. I think you've turned the word performance development or performance measurement on its head, the theme of empowerment also. So we've largely been speaking in the context of the rural scenario. And, you know, one of our audience, Anne, has been asking from the perspective of, let's say, efforts to replicate this kind of work in the urban health mission. What would be your thoughts? Amit, would you like to answer first?
Yes, sure. In context of participatory learning and action approach, it was tried in the urban context in Mumbai, in the slum areas, and the results were not as we have got in the rural context. But having said that, I will have to say that in urban context, we are yet to test it in the way where we can kind of say confidently that it works. Maybe if there are change in the design, change in the tools, maybe it can work. But so far, the urban experience hasn't been as it has been in the rural context.
Okay. Shuchi, Sumit, would you like to also bring in your thoughts?
Yes. Thanks, Preeti. So in terms of the urban context, my sense is that it's a very different context altogether, because what you're trying to say is that, you know, the hallmark of any community health worker program is her embeddedness in the community, her ability to sort of forge those relationships with the members. And when you look at something like an urban slum space, what you witness is there's a huge amount of heterogeneity. And there's a lot of migration and a lot of turn within the community. So I don't know whether that relationship is identical or similar to that of the community health worker and her community in the rural setup. So that creates an additional sort of layer of challenge of actually implementing or studying their relationship behavior and their empowerment. So as of now, I don't have anything to speak of in the context of urban areas, but I do think that it would require a very different and a very different outlook and a paradigm shift in how we perceive community health worker programs in rural areas when we look at urban issues. Thank you.
If I may add a couple of points, hearing to Suchi's conversation, I realized. One is that how these community health workers are perceived by the larger community. With my limited experience and exposure in urban context, I feel that there is a marked difference in the way community health workers are seen and perceived in the rural context compared to, say, urban slum.
Yeah.
In urban slums, probably they are seen as ones who deliver services, whereas the real role of ASAs, as it has been perceived, is to mobilize communities. And if you try and see it from the urban context, that mobilization, as Suchi also mentioned, becomes difficult because of the challenges which remain. So the population is floating. The context is very different. Priorities are very different. It's not a homogeneous or more or less homogeneous community. Where and in PLA context, the changes are observed over time. So it takes a couple of years, 3 years for that change to happen. In our context, probably that is going to be a challenge to get that community kind of have that patience and kind of continuously making the effort to bring that change.
And for the health worker to have ownership of the services she delivers. This might also be challenging because there are more options for healthcare in an urban context versus a rural context, right? And different meeting your cost requirements as well. So that might be an additional challenge as well. I do recall reading a statistic somewhere that the gaps in and the vacancies of ASHAs in urban areas was also correlated with higher incidence of COVID. This is from Maharashtra, as I recall. So this is also sort of telling that while there are multiple options and these community health workers have the choice to go to other occupations, this also has an implication on the health of the community in urban areas. That's all from my side. Thanks.
Sumit, any reflections you would like to share?
Yes, I think Shuchi and Amit are on the dot on this one. In fact, we have a PhD student who's working on this subject, and she has recently published in Health Policy and Planning a paper which examines, it's a scoping review, the unique and distinctive roles of community health workers in urban settings. And what I can do is I can plug in the link to the article. Don't want to be self-promoting, but since this has come up, into the chat box for people if they are interested. And I think Tara Lynn has done a good job there. She has, she has done a nice scoping exercise, and certain things she finds are quite common, the linking role, there is a potential, but certain things I think we need to tailor to the unique urban context. And one of them is pockets of marginality, pockets of vulnerability. And if whatever linking and reaching out kind of function CHWs do, that could be more directed, more targeted within the urban settings. But I invite you to read the paper that Teralyn has written. I think it's a nice addition to the conversation on the role of CHWs in urban settings.
Okay. So there are certain questions which have come in the chat where people are asking about let's say technology solutions, and has been mentioned. I think that's another webinar by itself. So all of you out there in the audience know that we are going to have a session which is focused on that. And like one of our speakers mentioned about the Asha's conclave, I think we would need to do a conclave just on the whole CHWs, because again, in the chat, people are talking about, whether it's perspectives from Bihar or Jharkhand, the other states where they have rolled out, they have experimented, what has been their experience are also some things to listen and learn from. So at this point, what I would like to do is, there are some questions on, when we are, like I think Sumit also had referred to it earlier, when we are talking about empowerment, it's also about power. So what is this concept of power? And so at this point, what I would like to do is get Priyananda back in to kind of reflect on that, and also to kind of summarize this very interesting discussion that we've had. So Priya, over to you.
Thanks, Preeti, and thank you to all the panelists. I think it's really been a very interesting 1.5 hours, and also active engagement from the audience, which I've appreciated. I think there's a lot of work being done at conceptual levels around power and agency, not just of frontline workers, but women in work writ large, women broadly, marginalized populations, vulnerable women. And I think we're all building on frameworks that exist to begin with, and all definitions, I think, go back to Naila Kabir, about the ability to make strategic life decisions for themselves, and really capitalize opportunities that are denied to them. So if I look at what we confer or how we define power for women, and if I think about it in the context of frontline workers, I don't think we are ever asking them, what are the strategic decisions for you in your work and in your life that have been previously denied, that can be enabled through the work you do, through the status that you gain in your communities, through the status and power that you can positively and affirmatively gain in your health systems and communities. Because the status and power that Sumit talked about, and that was also somewhat kind of negotiated in the chat, and I really like the way Sumit summed it up in the end, that is, in a way, what Priya Das has said, is sometimes a perverse use of power, right? And that is because that is what you observe in the system, all the way down in a very hierarchical, stratified system with dynamics of gender and caste. The way power gets enacted is in very perverse ways, because there isn't a systematic way that people understand power, with roles and responsibilities, with equal accountability up and down the system. Because of the absence and void of that, what happens is a whole shadow system of power and enacting of power gets created. And who would blame for community health workers to become part of that shadow system? And I think that is what Sumit talked about. Now, I would say, kudos, great that they are using and seizing that power. But I would say what he said in the end, that doesn't mean the state or the system abdicate their role in conferring positive and affirming power, which says, you are a community health worker, you are a professional, we recognize you and celebrate you for the work you do. You carry 70% of the burden of the health system in terms of primary health care. And therefore, at least 70% of the power could be potentially conferred to you. Now, that would be a very radical thought, right? That they have the decision making on their roles, not on their roles. Okay, the roles are defined, but on, how do they want to spend their day? How do they want to manage their time? How do they want to collectively organize themselves and organize? How do they want to report? How much data should be reported from them up the system? How do they want feedback from the system back on their own performance? All of this could be also power that can be systematically, institutionally conferred to them, but it isn't. The power that is being discussed is not that power. The power that is being discussed is in the absence of all of this, in the burden of having roles and responsibilities where you cannot negotiate. What you do is you negotiate what you can't do and you negotiate what you can do. And that is based on your preferences, on how you're remunerated and your context, and what you feel challenged by and what you don't feel challenged by. And that's where the heterogeneity emerges, because then every health worker is deciding how she wants to negotiate her context. Now that is power. Sumit is right to call that power. But we are also right to challenge that. Is that the power we want to talk about? So I think what we are ending up as a group here is to say there is power within and power to, but there's also power with and power from. And there is a question on the chat around collective power, which is being discussed in many ways by the Jharkhand example through participatory approaches, which is how does an individual's power aggregate and get amplified in the collective. Now, we do have examples of that. We know it does get aggregated, but even within the collective, there are heterogeneities. Even within the collective, there are caste issues. Jharkhand is not the same example as UP and Bihar, because Jharkhand is much more cohesive and homogeneous in terms of caste and ethnicity, I would contend, than Bihar is. And of course, I'm just making very broad brush statements here. But the fact remains that there is a whole set of issues around, okay, even at the power of the collective, if we say, emerges, but the power to negotiate within the system, the power to make their supervisors or even powers that be accountable to their roles, to their mandates, to their rosters, to what gets assigned to them and what gets deassigned to them. In the time of COVID, all of a sudden, the responsibilities of community health workers were magnified and amplified, and they didn't have a choice. And therefore, the only choice was to actually not do what you knew was essential work, till there was policy guidance that actually please don't ignore what is essential health services. Now, these are not choices that a community health worker can or is able to make at her level. It's only when a guidance comes or when you're zoomed in with additional training that you do that. In reality, she should be able to say, I have 24 hours in a day, I have responsibilities at home, and I have responsibilities in my community, as well as I have responsibilities of my work. And how do I negotiate and manage that? And what are the resources that I need from the system to help me manage that? I think, to me, if that is the level of discussion we can have at a very practical level, and then I think we have some legitimacy and groundwork to talk about power. Till then, I think we are still in a very conceptual space. Sorry, I think I went over the time that was allocated to me, Preeti. Thanks.
Thank you so much. I still see several questions. I'm going to take another few minutes to take up some of these audience questions. Sumit, maybe I would just ask you this question. The question says, Dr. Sumit, what would you say is the essence or the reason for the self-accountability that Ashas exhibit while working in their community?
Yes. It's a mix of things. And from what I found in a part of Maharashtra was that Ashas really wanted to make a difference. Ashas almost all Ashas felt that what they were able to do as a result of being part of the program was valuable, was important, it was to the extent that it defined their identity. We had a particular Asha who had just been elected a sarpanch, right? And we asked her, according to the rules, you have to forego either being Asha or being a sarpanch. What would you choose? And she said, it's a non-question. I would drop my sarpanch office. Asha allows me to do meaningful work. Asha allows me to contribute to my society. For others, it was about being able to step out of the house. For some others, it was about contributing to their own family. And to me, and there were other instances of, it was about resisting the in-laws. So subverting gender hierarchies and so on and so forth. And to me, all of this was exercise of agency. All of this was demonstration of, taking power, acquiring power, and not of being given it. So that was the point I wanted to make, that, okay, power is and Priya is right, you can look at power in many different ways. The feminist scholars and gender theorists and Naila and all of others have looked at it in many different ways. But one school is that underlying power and empowerment is conflict theory, that it is a tussle over resources, privilege, opportunities, so on and so forth. And we need to take that into account in whatever interventions we create. Interventions that only increase self-efficacy, which give people power to do something and don't give power over, can only frustrate people. And the good news is, it might frustrate you and me. Ashas are smarter than that. They know that they have to take things in their own hands, and we saw them doing that. Yeah.
Thank you. Taking up another question, which Manya Gupta has raised, how necessary is it to monetize CHW programs? How can LMICs afford to sustainably pay the very large CHW workforces they have right now? Amit, would you like to answer that?
Yeah, as I mentioned during the discussion also, that in case of most of Ashas, they are the ones probably in their family who decided to step up out of the four walls, and probably that was the first step towards empowerment of hers, if I may say so. And in last, say, decade or so, there has been a dependency both ways. So the communities look towards her as someone who can help us resolve some of the health-related issues. The other way is the family probably looks towards her as a potential member in contributing to the household economy. And we can't kind of ignore either of that. Having said that, as Dr. Sumit also mentioned, that it's their will and their commitment to make change in their lives of the communities that is probably the strongest force behind what they have been able to achieve, and they continue to do so. I'm not very sure how that can be complemented. Finance can be one of the aspects. Everyone needs that. They also need that. But in the current structure in which they operate, I think ensuring that it reaches there in time and they are able to use it for their own family, for their own betterment, would be my take on way forward with that. Thank you.
Could I come in, Preeti?
Yes, please.
Yes. So if I understood Manya's question right, I don't think it is a question of if, it's only a question of when. And And the when has taken so long because all Ashas are women, to be honest. Had it been men, this would have happened already. The formalization of the cadre would have happened already. The regularization would have happened already. I think we are reaching a point where this will happen. Now, can low and middle income country health systems find the resources? They will, I suspect. And as Amit pointed out, communities need Ashas. And if you go and observe what happens at the primary health centers, I think primary health centers desperately need Ashas. And all kinds of programs need Ashas. So they have proved their value. And now we see them organizing, speaking to Priya's point, we see them collectivizing. We've seen in your earlier sessions that you had organized, that they are all coming together. They are taking what is theirs, and if they get it, good on them. I hope they do. And I think it's a question of when, not if.
Yes.
I think even I would like to add to that point and build on what Sumit and Amit have spoken about. Yes, it is a question of when. And if we were to look at paying these community health workers as a, if you're trying to look at it as a balance sheet, then you might as well look at the benefit that these workers bring to the health systems, to the beneficiaries. And that would be a more realistic account of how well and how much they should be paid. And the bigger question of probably regularizing this pay is more to say that it's very tedious to track what incentive you're owed for what task at what date. So this simplicity would actually reduce their work burden and make them more efficient to be able to deliver. So it becomes, and as we see in India, more and more states are going to either full-time salary for Ashas or a hybrid structure, wherein they have one fixed component and some variable component. But this is trying to actually bring it up to scale and regularize these workers. And it's only time this happened. So that's all I wanted to add. Thanks.
Shuchi, maybe you can also just answer very quickly 2 questions. I'm just putting it together from our audience. So Tafiq has asked about how are AWWs recruited centrally throughout the government directly from community, one part. The other part is about have CHWs been sufficiently empowered to influence the local health system? So one about recruitment and about how do they influence the local health system from Dr. Raghupati.
So how they are recruited is that there is an official recruitment process. It's not like an ASHA process wherein you identify amongst the community. More often than not, most Anganwadi workers belong to the community itself, but there is an official recruitment process that they need to go through. In terms of how the health workers, I'm sorry, can you repeat the question? How they have been empowered to perform within local health systems?
Yes, how are they empowered to influence the local health system? Yes.
Thank you. So I think there are 2 ways to answer this question. What we see right now is that they are at the lowest in terms of the hierarchy in their ability to influence change. But what we do see is that because of their connection with these complex systems that they work in, complex adaptive community health systems that they work in, they're able to maintain those relations to actually influence some behavior. So to give you an example, based on a study that we did a few years ago with Ashas, what we see is that when there is reluctance to take up a specific service, she reaches out to, say, the panchayat, a member from the Panchayati Raj institution, or a supervisor, or she reaches out to the neighbor of the beneficiary to convince them to carry out, to take up a specific service. So the embeddedness sort of works as a means through which she can actually influence some kind of change. In terms of raising voice to and problem solving, that seems to be problematic because it is at the end of the day a very hierarchical cadre, and she needs to find opportunities to raise these issues. And what we see is this is the point where we need stronger supervisors who can raise these system level issues. Like, you don't have complete drug kits. How do we raise this issue? You don't have enough beneficiary turnout. How do we raise these issues? So while there are efforts at the community health worker level to systematize this, we need a stronger cadre of supervisors for these health workers. Thank you.
Okay. I think, Suchi, I'm just going to give you one more question, last one. There's a question which says, when the beneficiaries denied taking services from the Anganwadi worker from a lower caste, in such instances, how did the Anganwadi worker negotiate and manage the situation?
So the answer to that is a little complicated, because what I can say is that she attempted to talk to her supervisor, or she attempted to speak to the ANM or the ASHA to convince this beneficiary. But at the end of the day, I mean, it does become the question of how she negotiates these difficult scenarios, right? To give you an example in the context of ASHAs, when such challenges happen, what we see is that she's also seen to, ASHA seen to tailor her service delivery based on the caste of the beneficiary. One of our studies showed that, members of a specific caste have more children. So she targeted them for the institutional delivery services, and a particular caste group for the immunization service, but she wouldn't. But she was sort of okay with knowing that a particular percentage of the people may not be covered, because it's just that much harder to ensure full coverage. But to negotiate these challenges wherein caste becomes a determinant of saying no to a service, she relies on her embeddedness and her community network. So that's the answer to that. Thank you.
Okay. So we've already exceeded our time by 10 minutes. So I'm going to bring this to a closure. I think a few of the questions which are still there, we would probably get back by email. There'd probably be a feedback form which would be sent to you again by email, which all of you can fill. And we definitely look forward that you should be joining in the upcoming webinar series. Again, the update will come to you by email. And as we conclude, we started out by talking about the frontiers of community health workers. And this was brought forward through research, which has probably spanned several years, spanned across states through multiple collaborators, very, very good research rigor. And we did not spend too much of time listening to the research methodology part, but considering the publications, you can imagine how rigorous the studies have been. And this has really taken the research or the evidence forward. And every good research also throws up one evidence of the next round of research or a newer set of questions. So we have questions which audiences asked about urban health context, how? So we need to look at all those evidence. We understand that we're not really talking about performance of the community health workers, because that seems to be a given from the research, intrinsic motivation. So many points, so many evidence points out to the fact they are working despite everything. So jugaad, so to speak, and a lot of local resource mobilization influencing that they are able to do. So considering that, we are talking about performance rather of the health system, the enabling health system, which needs to enable this particular group to even do better. And empowerment of their work should not take their work for granted, which means benefits, incentives must be given. It must not be something which is a fight, and we are still talking about the when part of it. And finally, it is really talking about empowerment for a resilient health system. That's what everybody wants. And on that note, I'm going to be concluding. I'd like to take a moment to really thank all the speakers who have given time. I think it's amazing that you kind of summarized everything in just those few minutes that you had. Really like to appreciate Priyananda, who really thought about this and really initiated this whole series and ensured research it's not just about some papers, but really a lot of discourse and discussion to take this forward. So I think many more would be coming. Thanks to the OPM team and the WGHI team. And thank you for this opportunity, everybody. We look forward to more questions. The presentation will be available as well as the recording. Thank you very much.